So, our first speaker is unfortunately unable to be with us in person today, but she recorded her presentation for us. So, Dr. Christina Chadwick was actually my CF GI clinical fellow and then was a Digest awardee. She is currently clinical assistant professor at the University of Florida, and she will be presenting the topic pancreatic function on HEMT. Should we be adjusting enzymes? So let's hope the video works.
Good afternoon, and thank you so much for inviting me to speak today. This session's purpose is to delve into exocrine pancreatic function and the question of should we be adjusting enzymes, especially on highly effective modulators. I have no disclosures to report. And these are the overall objectives for the session: to discuss the changes and nuances in GI care for patients on highly effective modulators, to illustrate and appraise the current literature for best practices in GI care, and to summarize the ongoing and developing challenges we face in GI care for patients on highly effective modulators. And specifically for this talk, we'll be reviewing exocrine pancreatic insufficiency, or EPI, available diagnostic testing and treatment for EPI, including pancreatic enzyme replacement therapy, or PERT, and the evolving role of PERT in the era of highly effective modulators. So first, we'll discuss the role of the exocrine pancreas, which includes production of alkaline fluid that helps in intestinal digestion. It's also responsible for enzyme production that aids in digestion of fats, proteins, and carbohydrates. These enzymes are broken down into three categories: lipolytic enzymes, which digest fat; proteolytic enzymes, or proteases, which digest protein; and glycolytic enzymes, or such as amylase, which aid in breaking down carbohydrates. So when CFTR protein is mutated, it leads to pancreatic dysfunction and associated complications. The CFTR protein lines the ducts within the pancreas and is responsible for bicarbonate and chloride exchange. When there's CFTR dysfunction, there's lower pH due to decreased bicarbonate secretion, as well as decreased secretory volume and higher protein content within the pancreatic ducts. And this in turn leads to acidomal plugging and dilation, as well as subsequent inflammation, fibrosis, and fatty infiltration, where functioning pancreatic tissue should be. And this is a diagram which lists multiple manifestations that one may encounter with EPI, or exocrine pancreatic insufficiency. And EPI can be associated with multiple GI symptoms, including abdominal pain, diarrhea, steatorrhea or greasy stools, bloating and increased gassiness, as well as weight loss and multiple nutritional deficiencies. And in terms of diagnosing EPI, there are multiple approaches we can take, and including direct and indirect testing. So direct testing includes endoscopic pancreatic function testing, as well as secretin-enhanced MRCP pancreatic function testing. But both of these can be cumbersome and potentially involving anesthesia exposure, invasive in terms of endoscopy, and not as readily available in comparison to indirect testing. So indirect testing, specifically fecal elastase, tends to be used much more often and is more practical and repeatable compared to the rest of these tests. Quantitative fecal fat measurement is the gold standard, but fecal elastase tends to be more utilized clinically. Other ways to evaluate for EPI is looking for fat-soluble vitamin deficiencies, as well as serum immunoreactive trypsinogen, or IRT. And even breath testing techniques have also been proposed, but more so in a research-based setting rather than clinical practice. So when using fecal elastase to diagnose EPI, less than 100 micrograms per gram is considered severe, whereas 100 to 200 is considered moderate, but over 200 is considered a normal value. And it's recommended to screen for EPI at the time of CF diagnosis, really regardless of when that is or what age it's at. For infants with normal fecal elastase, it's recommended to retest at 1 year of age and annually, or more often if they develop symptoms of EPI. And even if they don't have apparent symptoms, if they do have a more severe genotype or severe CFTR mutations, one would have a lower threshold to consider earlier testing as well. And if a person has clinical symptoms or signs of EPI or too severe CFTR mutations, then it's also recommended to start pancreatic enzyme therapy or PERT while awaiting the results of a fecal elastase or pancreatic function testing in general. One would also want to test for fat-soluble vitamins and look for deficiencies at EPI diagnosis and at least annually going forward from there. So currently available pancreatic enzymes are porcine-derived and include a certain ratio of lipase and protease and amylase. And these are the current recommendations for dosing, whether it's weight-based or based on fat grams per meal and snack. However, there's currently no reliable available test to determine what is truly the appropriate dose of pancreatic enzymes for each individual with EPI. What is available, as I mentioned, the quantitative fecal fat measuring or a coefficient of fat absorption, or CFA, which is a test that was developed in the 1950s and helps to quantify the amount of fat that remains in stool after digestion or lipolysis and absorption of fat. It has been used for diagnosing exocrine pancreatic insufficiency, but also to determine if pancreatic enzymes are being effective or not. Pancreatic enzymes have played such an essential role in the nutritional status and avoiding their repleting nutrition in people with CF, and it's truly the mainstay treatment for malnutrition and EPI in general. Thus, determining the correct dose of PERT is very important. When pancreatic enzymes initially became available, it was used to help reverse malnutrition in such a critical way for this population. And so pancreatic enzymes didn't undergo more typical safety and dose determination testing at the time. And after observation of increased cases of fibrosis and colonopathy and the suspected potential association with higher pancreatic enzyme dosing at the time, the FDA regulated a cutoff dose to limit the amount of pancreatic enzymes used in hopes to prevent further cases of fibrosis and colonopathy. And CFA, or coefficient of fat absorption, was used as an endpoint. But moving forward, there hasn't been any true correlation between CFA and individual pancreatic enzyme dosing with the currently available porcine-derived pancreatic enzyme formulation. And in terms of the reliability of change in clinical symptoms and pancreatic enzymes, there have been multiple studies that have looked into this and examined this question. And there seems to be that in people with CF who have been on pancreatic enzymes compared to placebo or without, there has been some noted improvement in abdominal pain and flatulence compared to placebo, but the most consistent finding was improvement in stool number and consistency. However, when comparing rates of GI symptoms at differing pancreatic enzyme dosing, this study that included over 1,000 children and adults with CF found that self-reported GI symptoms and stool number didn't really correlate with individual pancreatic enzyme doses. So although being on some pancreatic enzymes overall will likely improve symptoms, these findings suggest that just because someone is on a certain pancreatic enzyme dose and it is increased in hopes that it'll improve symptoms or resolve certain GI symptoms, it won't necessarily lead to this. And when putting the coefficient of fat absorption against varying doses of pancreatic enzymes as well, there wasn't a true correlation seen between these two variables either, which suggests that either the coefficient of fat absorption as an endpoint isn't really a valid measure of lipolysis, or that perhaps porcine pancreatic enzymes don't work as well as once thought, or both possibilities. And even in people who have not had full restoration of pancreatic function or normalized fecal elastase, we have seen that these individuals or multiple people with CF have been able to cut their pancreatic enzyme dose down but still do well. This 2017 meta-analysis looked at individuals with chronic pancreatitis actually rather than CF, but still with EPI. And it included 14 randomized control trials of adults on pancreatic enzymes. And this graph in particular depicts what range of enzyme dosing was used. And these individuals had improvement in coefficient of fat absorption when on pancreatic enzymes. But as you may be able to see, based on this graph, at much lower dosing than what is typically used in CF-related API. So for example, a person with CF taking 4 Creon, 20,000 with meals and 2 with snacks, that would be closer to over 300,000 lipase units a day. But on the right, the graph with the horizontal blue line representing 50,000 units a day, although there's variability in the range of enzyme dosing that was used amongst these studies, it is overall lower compared to pancreatic enzyme dosing that we see in people with CF. This study found that there was an insignificant increase in CFA with higher dosing, but even at higher dosing still, it did not fully correct malabsorption either. So this suggests that, potentially pancreatic enzyme dosing has historically been too high, or at least higher than needed to avoid malnutrition and also symptoms of malabsorption. Therefore, due to the limitation of CFA and its lack of correlation with pancreatic enzyme dosing, other tools are being explored to find more reliable testing for lipolysis and absorption, such as the substrate absorption challenge test. And in this test, a known quantity of oral DHA triglyceride is given with a high-fat meal. Because baseline levels are very low in people with CF, and because there's almost no endogenous generation of DHA, the amount absorbed should reflect the action of what lipase is being used. These data are from an EPI pig model. And in this study, pigs were given a high-fat diet and then underwent ingestion of a standardized omega-3 substrate, and subsequently were given different dosing of a novel or new microbially derived lipase, unlike currently available porcine-derived pancreatic enzymes. And what was observed was that as the dose of this lipase increased, there also was a significant increase in the absorption of omega-3 fats as well compared to when no lipase was administered to these pigs. So this omega-3 substrate absorption challenge test could be used to determine more accurate, appropriate dosing for pancreatic enzyme therapy than what is currently available. When reevaluating how we dose pancreatic enzymes, we also need to consider the potential effects of highly effective modulators on exocrine pancreatic function, which could influence the amount of pancreatic enzymes actually needed for adequate lipolysis and absorption of nutrients. CFTR modulators are medications that include correctors and potentiators, which act on the protein to improve folding and trafficking to the cell surface, and also gating function at the cellular surface, respectively. Ivacaftor and elexacaftor, tezacaftor, ivacaftor, or ETI, are considered highly effective modulators and have been associated with positive clinical outcomes, including improved pulmonary function, weight gain, and also exocrine pancreatic function. And within pediatrics, there's been multiple studies looking at the effect of these highly effective modulators on restoration of pancreatic function by using or measuring fecal elastase after treatment initiation. The RIVAL study, which was a 2-part phase 3 clinical trial, first examining patients from 12 to 23 months on ivacaftor for a duration of 24 weeks, and then subsequently in part 2 of the study involving younger infants from 4 to 12 months. This study showed that there was a significant improvement in fecal elastase by 24 weeks. And also over half of patients who were exocrine insufficient at the beginning, at baseline, had normalization of fecal elastase by the duration of the study by 24 weeks. Additionally, the KIWI study and CLIMB study, which is an extension of KIWI, also looked at pediatric patients, but at an older age from 2 to 5 years at enrollment on ivacaftor, and saw that 23% had normalization of fecal elastase by 24 weeks. The PROMISE study, which was more recently published than the former two, was a 56-center prospective observational study that looked at patients 12 years and older that qualified for ETI and were on ETI, and they noted that there was no significant change in fecal elastase over the 6-month period, and therefore no improvement in EPI. Whereas compared to arrival, patients were much younger in age and infancy. So these findings suggest that if a modulator is started earlier in life, and also potentially in a person with a higher baseline fecal elastase, there's likely a higher chance of achieving pancreatic sufficiency. Additionally, a recently published multi-center pediatric study looked at the effects of modulators on restoration of pancreatic function, as well as potential outcomes with pancreatic enzymes. This study included 70 pediatric patients, 78% of which were on ETI during the study and had been on a modulator for about 3 or more years prior to fecal elastase testing. They noted that there was a significant increase in fecal elastase from a baseline value that was checked prior to modulator use. And during the study, 21% of patients became pancreatic sufficient. And they noted that there was a better chance of reaching pancreatic sufficiency at a younger age when starting modulator therapy, as well as if you start with a baseline elastase that's higher. Do you know what? Out of these 15 patients that they captured who became pancreatic sufficient, 13 of these were able to stop pancreatic enzyme therapy during the study. And this is an algorithm that was designed by UNC Medical Center, which was one of the institutions participating in this study, as mentioned on the previous slide. And for those who regain pancreatic function determined by a normal fecal elastase, over 200, they suggest that pancreatic enzyme weaning can be considered. And this is described in the lower outline box here by decreasing the pancreatic enzyme dose by 50% in the first 1 to 2 weeks, and while monitoring for signs and symptoms of malabsorption. But if none are detected or encountered, then it should be okay to stop pancreatic enzymes with close follow-up and monitoring. And also by next follow-up, rechecking fat-soluble vitamins, because there may be room to switch to a regular multivitamin as well. So even though recent studies are very exciting and promising for those who may become pancreatic sufficient and therefore be able to wean and stop pancreatic enzyme therapy, which can be quite cumbersome to take on every day on every meal and snack basis, the question though still remains, is restoration of pancreatic sufficiency permanent? And in this multi-center study, which included 2 to 5-year-olds with CF, it was noted that even after 6 months of evaluation, if modulators were stopped within 2 weeks, there was a decline in fecal elastase in some individuals. And this suggests that, at least for certain individuals with pancreatic sufficiency, it may be dependent on modulator use still, and it's not a permanent status if modulators are stopped for a number of reasons. And so after discontinuing pancreatic enzyme therapy, it is recommended to closely monitor these individuals and anthropometrics, as well as checking a fecal elastase at least annually, if not more, if one develops symptoms or signs of malabsorption. I'd also recommend monitoring fat-soluble vitamins at least annually as well. And if a highly effective modulator is stopped for any reason, it's important to recheck a fecal elastase within 2 weeks of stopping therapy, as some individuals, as previously demonstrated, may become exocrine insufficient again, and in such a short time period as within 2 weeks after stopping a modulator. So in summary, we need better tools to determine appropriate pancreatic enzyme dosing, and these may be on the horizon. Lower doses of pancreatic enzymes may be adequate, even in people with CF, or with people with CF and EPI. And highly effective modulators have been shown to restore exocrine pancreatic function when started earlier in life, and also with longer use. Fecal elastase is a good screening tool for exocrine pancreatic function and should be repeated. There's some variability, particularly when there has been a change in therapy or symptoms, as restoration of pancreatic function may not be permanent for everyone, especially after cessation of a modulator. Thank you very much.
So we would certainly like to thank Christina for an excellent presentation today. Unfortunately, she's unable to take questions. So we're going to move on to our next speaker, who is Dr. Jake Robson. He is a former Digest awardee from 2016 to 19. He's a pediatric gastroenterologist and associate professor of pediatrics at the University of Utah School of Medicine. He participates in a multidisciplinary CF clinic at Primary Children's Hospital CF Center and has been the primary mentor for the CF Foundation Clinic Fellowship Award for 2 recent University of Utah Pediatric GI Fellows. He also received career coaching from Dr. Dick Grand while a pediatric resident at Boston Children's Hospital via the Digest Award. Thank you, Jake.
Thank you for having me. Thank you for the invite and to the program planners. I'm going to take my first minute and tell a story about Dick. I was a second-year resident at Boston Children's thinking about applying to GI Fellowship, and I told my mentor on the ward team I was on that I was thinking about going out west for GI Fellowship, and he said, "What, like Cincinnati?" And I said, "No, I was thinking about San Francisco, where I'm from." "Why do you want to go there?" And I told the same story to Dick, and he said, "You'll be fine. It'll be great. You'll find wonderful people to learn from." And I think that kind of summarized him for me as a person, someone that really treated others like he wanted to be treated. And he's just uniformly described as one of the kindest people that most of us have ever met and ever worked with. So I just wanted to share that. And I think my experience working with him has been uniform to what others experienced. So today I'm going to talk about rethinking placement and removal of gastrostomy tubes or enteral feeding tubes in the highly effective modulator era. Not going forward. Can I use this? That'll work. So I have no disclosures related to this talk. I participate in an EOE Speakers Bureau, but nothing to influence the slides today. So hopefully at the end of this 20 minutes or so, I'll have given you a roadmap of where we were in this decision before modulators came about, where we are now that modulators are available for many patients and influence this decision, and then where we're going as we get more data with patients on modulators longer term. So we used to think about this a lot prior to modulators. And I just want to quickly highlight the basics that we know that poor growth is a common thing in children with CF, that infants and toddlers really struggle to get the calories they need to grow. As we just heard, they struggle with pancreatic insufficiency. Can still be, even with appropriate enzyme replacement, there can still be malabsorption of vitamins and nutrients. And they have increased energy expenditure from chronic disease, all of which can make it hard to grow. And we know that growth is a key metric because there are many early studies of early growth that show an association between poor growth and poor CF clinical outcomes throughout life. Poor early growth in children with CF have been tied to worse lung function throughout childhood and into adulthood, worse growth into adulthood, and truly worse transplant-free survival. This is also true in adults with CF that may have low weight and BMI tied to worse lung function, worse prognosis with CF-related liver disease, and worse overall survival rates. So for those of you that are visual learners, I'm going to put up a couple kind of graphs that really bring this to light. This is sort of the one that I show students and residents I work with most frequently, going back to the registry study from Dr. Stallings in 2008, showing that especially in females, in young females with CF, when we stratify weight for length percentile at age 2, all 3 cohorts, except those above the 50th percentile, go on to have lower PFTs, FEV1, throughout their childhood. This is a little bit different in boys, but similar, that the lowest group, those below the 10th percentile in weight for length, sort of really have notably lower PFTs throughout childhood. this has been shown a couple different ways. So this is by Dr. Elizabeth Yen from the mid-2010s in the Journal of Pediatrics, showing that survival is notably lower in those in both the lowest weight and height percentiles. And then also there's, now that we typically plot patients on WHO curves, this is from our center in collaboration with a co-fellow of mine, that those that hit the benchmark of the 50th percentile on the WHO curve, but not the CDC curves, are still at higher risk of mortality. So we seem to know that bigger is better. But that's a little bit more complicated than just a uniform statement. And so this is in clinical research, this is what's called a directed acyclic graph, showing that there are multiple confounders here in the middle, such as CFTR mutation or lung disease, that can influence both poor early growth and the poor outcome. Now, the things that you're seeing on your left are the things that we as CF Center participants think that we can hopefully modify. So the meds that patients take, the resources that they have, the counseling they get from our center. And so this led to the big question in the pre-modulator era of, if kids are behind in their growth, can we make them bigger so then they will do better? And that has always been, I think, one of the most interesting questions in CF nutrition. So probably the most important work of the last 15 or 20 years that helped answer that question comes from the first study, or Feeding Infants Right from the Start. So initially, they were able to make a group of what's called responders. Infants that were able to get back to their birth weight Z-score by age 2, and they were called recovered, or the responder group. And followed over time, it was noted that the recovered group maintained their growth and had better lung function, fewer symptoms, and less findings on imaging. And amazingly, and this is the beauty of longitudinal cohort studies, this group maintained those gains all the way up into kind of middle school age. So this is, I think, the best evidence that yes, we actually are doing something with our care. And yes, potentially early growth is a modifiable risk factor. And if you can get kids that are kind of floundering a bit into the more normal growth categories, they may be able to enjoy those better long-term pulmonary outcomes. So this is an interesting graph because this shows that as far as our nutritional goals in children with CF that are between the ages of 2 and 19, we're trying to get them to BMI of the 50th percentile. So interestingly enough, we were actually making great progress, and about half of patients were at goal by about 2007, so even before modulators. So why was that? Why were patients displaying improved nutrition or improved BMI prior to modulators? So I think it's multifactorial. One is this kind of does mirror our trends in the United States. Kids are eating energy-dense foods and are getting bigger. But also I think it really speaks to the importance of multidisciplinary CF clinics. Many of us have the good fortune of working side by side, and I see some of my colleagues here in the room, with experienced dietitians, with feeding-focused psychologists, social workers to address food insecurity, pharmacists to think about periactin and other appetite stimulants, nurses to ensure good coordination of care. This makes a huge difference in getting patients to gain weight. And also I want to highlight the CF Digest Award, where now 50 plus gastroenterologists have had dedicated time to learn more about CF and to really get involved in these clinics. I think that has contributed over these last few years as well. So this is an algorithm that we've used in the past in patients that weren't gaining weight well. And so we kind of would step through, is there pulmonary or sinus disease? Are there signs of malabsorption where potentially enzymes could be adjusted? Have they seen a dietitian and a behavioral therapist? Have we ruled out CF diabetes? And then we eventually come to the consideration of enteral tube feedings. And so in real life, and I'll leave this up here for a while, This is both thinking and feeling. We know the data, but there's a lot of feelings and the patient relationships that come in play here. And so some of the things that I think can be not concerning that we deal with a lot at our center are the child is happy, the child is feeding well, the family is tall and thin, and they say, well, the child looks just like me. Height percentages are good. The lungs are getting tall and have extra space. There are no pulmonary concerns. They show up to their clinic visits. The parents are experienced. They have resources. On the concerning side, as far as when a child's not growing, I get concerned when the parents are not concerned. And I, certainly worry when growth is worsening, when we're not taking supplementation well. I do worry, honestly, that sometimes we as the physicians that want to do something are more likely to push towards G-tube because that's something that makes us feel good that we're doing something, and I'm not always 100% sure that's the right thing. So what about the data of gastrostomy placement? I think every time I go to the literature, I would think there would be more than there is. So there's 3 studies that are of kind of decent size. The biggest is from the University of Minnesota with up to 4 years of follow-up. And it does seem that in all of these smaller studies, the children gain weight when the G-tube is placed. And they don't have super long outcomes, but in the longer outcome studies, it does seem like their PFTs improve. But in a Cochrane review, they kind of highlighted that we have 44 trials, but really no randomized control trials. So when it comes down to the gastrostomy decision, what I highlight as far as potential positives are, it can definitely take pressure off of the patient and family. We've had some, sobbing encounters where people are doing everything and it's just not helping as far as improving nutrition and other medical issues. These parents and patients already do a lot in their medical routine, so adding this is sometimes not seen as too much. And it can be really good for children that are active and just need that extra boost. It can be utilized in times of illness for meds and hydration. And it can be a tool when all else has failed, kind of referring back to the sobbing encounters where folks feel like they have done everything and we need to think of something else that we could utilize. The negatives are not zero. I really try to highlight to everyone that placement of an enteral feeding tube has pros and cons, and it can feel like a punishment to the family and the child. It can feel like a failure, and there can be body image issues as far as thinking about sports and time at the pool, and these were actually well characterized in an older paper from our center, they can rarely have complications. They may not work, and there's just not a clear algorithm to decide when to place a gastrostomy tube. So what I would say is, G-tubes help, but so do we. This is some data from our center that's been presented here at NACFC in the past. So we had 156 children in a study, and 78 with a G-tube and 78 without. And we did our best to match them by age and BMI and gender. And pretty interestingly, things turned out about the same over 5 years. Now, this was retrospective. It was a single center, and it was tracked before and after tube placement. So certainly it's possible that we are better than we think at just identifying who actually needs a tube and who doesn't. But I want to highlight that in the children in the less than 10th percentile, those that got a G-tube and those didn't, their outcomes were really quite similar 2 and 5 years after placement or after baseline. And the same thing is true in those in the 10th to 25th. So these are the kind of the groups at the higher risk that we're always debating G-tube placement. And so this kind of gave me some pause about how aggressive to be with placement in patients that are maybe starting to hold their own. As far as adult data, it's relatively similar. There's a couple studies that highlighted the improvement of nutrition in patients on getting a gastrostomy and enteral feeds. But they're more often utilized to aid patients towards transplant or to kind of improve their nutrition temporarily. So what's the summary of the pre-modulator era? Is that there was, I think pretty compelling data in our ample clinical experience that gastrostomy insertion for enteral feeds can help nutrition and may play a role in improvement of long-term overall clinical outcomes. This is very complex and multifaceted, but in the right context, if the child is not doing well or the adult is not doing well despite maximal effort from the team and from the caregivers, or if the child is struggling and it's a very high stress situation, tube feeds can help take some of the pressure off to get nutrition without causing worsening mental health issues. There is not a clear algorithmic evidence-based decision support here. But I would say it's not clear from this first part, the pre-modulator era, that avoiding tube placement was inferior. And this was before modulator use. So, what about removal? So there's definitely no data on removal. So the compelling reasons to take a G-tube out are complications, pain or vomiting, when a patient's not seeming better, or when they have, notable body image reasons. This is what we say at our center, which is 6 to 12 months without using it, with, obviously maintaining nutrition goals, and then at least one notable illness without having to use the tube for fluids or meds or nutrition. And I would say overall, it's rare that we tell a patient to remove a tube. If it's there, we say, well, you might need it in the future. Why don't we just leave it? But so it's usually patients that come to us asking for it to be removed. Okay, so this part's going to be shorter because we're just getting into this era. And so I highlight here when we crossed our goal, the 50th percentile. And then the purple line is when ivacaftor came out. So we were already headed in the right direction. And I just want to highlight now that, 60% of kids and 65% of adults are meeting their nutritional goals. I think that's probably due to the hard work of all of you in the room. And now we're up to, something around 85% of patients qualifying for modulators. So we know, and it's most clear on ivacaftor, that both weight and height seem to improve in patients with CF taking the modulators. So, here we have the initial data on ivacaftor as well as some pediatric data for height, and then here's weight. And, why is this? I highlight a couple things. We heard about how it can improve exocrine and pancreatic insufficiency. It can it can lead to decreased energy expenditure. It can help change your microbiome and decrease calprotectin. Interestingly, growth, also seems to be aided on ETI. And so here's, adults with their change in BMI. These gains seem to be sustained, so it's not that they're eventually needing enteral feeds after a couple of years. They seem to be doing quite well with growth sustained just taking this medication regularly. This is some more data on improvement in BMI. I do highlight that even in kids, the height gain is a little bit less robust than the weight gain, and that might be something to keep a close eye on over the years, whether we focus more on height gain as a marker of true nutritional sufficiency and CF outcome prediction. Two additional considerations in patients on modulators. So this was mentioned that now patients are getting modulators younger and younger and younger. The younger you get it, the more likely it is to wake up those amazing pancreatic progenitor cells, to fix some microbiome issues. So I think we may see even more benefit down the road. And secondly, we already heard this, so I'll go through it quickly, that some of these patients, especially those on ivacaftor that get it early, might flip back to pancreatic sufficiency from a previous EPI status. And in a lot of these patients, you can not only stop the enzymes, but also they may not need these broken down feeds that can be hard to take. Some patients have a gastrostomy place just because they can't tolerate or love the taste of the formula. Okay, so summary on the modulator era that we're in now is that it seems like they help a ton with nutrition. And we still are in the era where, I expect that insertion may decline in patients that are maintaining growth goals. But we still have to keep a very close eye on a certain subset of patients, right? Those with an entrenched feeding problem, this recently described entity called ARFID, or avoidant restrictive food intake disorder. Those with short bowel syndrome, maybe from an intestinal resection with meconium ileus. Those with poor growth despite maximal intervention, they still may need G-tubes. And those with severe disease where they need extra nutritional support, or those that don't meet criteria for a modulator, and I'll come to that in a minute. So as far as removal, this is exciting. This was presented at last year's NACFC, I believe. We might get to use some of our endoscopic clips to close cutaneous fistulas. So it seems like patients are tolerating getting their gastrostomies removed. And those, especially adults that are already on gastrostomy, seem to be using them about half as frequently. So I think a lot of us feel like CFTR modulators are coming to the rescue of these individuals. Okay, so last, the future. So issues on the horizon. We still are going to need to keep a close eye on this certain subset of patients. Because a patient gets a modulator, if they aren't growing, that would still put them in the category where you would strongly consider gastrostomy placement for enteral feeds, or patients with other specific issues. But this is balanced with kind of this new phenomenon we're seeing, right? Being overweight in cystic fibrosis. And I think a lot of us have to challenge ourselves to do both the thinking and the feeling, not just base everything on some of the early data and, oh, this patient's been below the 50th percentile for a couple of visits in a row. We got to get a tube in them and get enteral feeds going. Rather, I think that modulators may allow us to just continue the multidisciplinary care, but not rush to tube placement. And then lastly, and this has been a hot topic at this conference, which I'm very glad about, there's still a decent portion of patients that are not eligible for modulator therapy, and they will have to be carefully monitored for the nutritional support in a much more diligent fashion. So interestingly enough, while newborn screening has greatly improved delays in diagnosis, notable racial disparities in CF diagnostics remain. And this is a small portion of the CF population overall, but there continue to be disparities in state to state newborn screening as far as how many genes are covered on DNA testing. And then just to highlight, Black and Hispanic people make up with CF make up 40% of patients that are not eligible for modulators. And while over 90% of non-Hispanic whites have a modulator available, less than 75% of Black and Hispanic patients do. And so, and notwithstanding, the Black and Hispanic children with CF have nearly twice the risk of mortality by age 18 compared to non-Hispanic white children with CF. So this group absolutely will need our careful attention and thought as we consider enteral feeds moving forward. I'm out of time. I just want to say that I really hope that we continue to focus on the ability to do longitudinal studies through the registry. Now that patients are on modulators, it's absolutely our job to track them going forward and to see how we're doing in those that do and do not get gastrostomies and how we're doing with our multidisciplinary care. Thank you for your attention. I'm happy to take questions.
We'd love to take questions from the room if there are any. Otherwise, we do have a few questions from online.
Hello, terrific talk. Thank you. Zev Mekon from Valley Children's. My question is around timing of a G-tube. If you think that this is likely somebody that needs it, is there a particular time that we should have it in by? Remembering that you said if they have a better BMI at age 2, then that tends to be more long term. So should we have it in by a year and a half, or now that we know that once they're 2 and they can get Trikafta, their weight's going to take off? Maybe we don't. That 2 is just like somewhat arbitrary and not as important as it had been in the past.
Yeah, that's a great question. I think you nicely highlighted the potential pros and cons on either side. So I do highlight for families that, especially in infants and toddlers, when the tube goes in, the oral feeding can really fall off. In patients with any early oral aversion that a tube goes in, they often stop eating completely. That's my clinical experience. So it is important to identify those that I call in like the severe or super danger zone, those below the 10th percentile in weight for length, those with other early pulmonary manifestations. In those patients, I think I would still strongly consider pulling the trigger early with the family knowing the pros and cons. Even with them heading towards Trikafta. I mean, I think a patient with a BMI or early weight for length at the 0 percentile, I don't really feel like we should wait until they get to 2 just to see what happens. In someone in the 10th, 15th, 25th percentile that is showing stability, I might be more inclined to wait. So that was more my own clinical experience, but I think weighing the pros and cons is very important. It's not wrong to go early. You just have to be able to live with the potential downsides of developing oral aversion.
Thank you.
Yeah, thank you.
We'll take a couple from online. You were asked, could the minimal improvement in height be related to studies being done in older children with less ability?
Yes.
Less ability for improvement in height gains.
Yes, I think so, right? Like, so, yeah, the adults that get ivacaftor don't gain a lot more height. I think, yeah, the older children are gonna, potentially have less height potential to catch up. It's relatively small sample sizes that have really been tracked. And I think as we get more data in those that were both aggressively supplementing and that get an early modulator, I'm hopeful the data may look different with improved height gain, but if it doesn't, if we track that and it doesn't look better, that will be very interesting to consider interventions around.
Excellent. And the next one was, do you think it is an important model for pediatric CF care centers to include feeding therapy evaluation in young children with CF?
Yes. Strong yes. And I want to highlight both aspects. So there's the feeding therapy aspect, a trained occupational therapist that focuses on the mechanics of eating, the chew, swallow, textures. And then there's the behavioral therapist. And I think they often serve different roles where the behavioral therapist can, be sort of the referee between the child and the family members that are trying to feed the child, and can really help suggesting behavioral interventions. They're truly providers that work together but do different things. And I think having both is really important.
Great. Thank you so much.
Thank you for having me.
Jay? No, it's Jay. Okay. Our next speaker is Dr. Jay Freeman.
All right. Okay. So Dr. Freeman was in my digest class and has been a collaborator with me on the Galaxy study. He has also played an instrumental role in the PUSH study, which was looking at ultrasound in the detection of liver disease in children with cystic fibrosis. He's currently professor of pediatrics at Ohio State University College of Medicine and director of the Pancreatic Care for Pancreas and Liver Care Center at Nationwide Children's Hospital. He's going to try to help guide us in one of the most difficult questions that we're getting as GI and liver docs in CF care, what to do with liver abnormalities beyond the medication label.
Thank you so much. Appreciate the opportunity to be here. I wish I had a Dick Grand story to share with you other than to say sometimes the greatest judge, I think, can be from afar. And there's no doubt that every one of us in this room that's been through Digest and kind of taken this up as a career path have benefited from him in some way. So, Sabina, thank you so much for those kind words. Those were awesome. Hope everybody enjoyed them. As Meg said, I have the task of discussing liver test abnormalities beyond the medication label. This is 2 conferences in a row, I think, where I've given a title where I had to sort of interpret what was being asked of me. And the way that I interpreted this was, we have ETI. You might have seen a patient or 2 with increased transaminase elevation. And what do we do? How do we interpret that? And what are we going to do moving forward? So that's kind of the journey I'm going to hope to take you on today. These are my disclosures, none of which are really pertinent to today's talk. Our objectives are to start with, what does the ETI label say and why does it say it? We're going to review the liver adverse events data from the clinical trials very briefly. And then I want to touch on some of what we're going to consider the real-life liver experience and how it might actually differ quite a bit from what we saw in the clinical trials. And then one of the questions I get asked a lot, I don't know about everybody else in the room though, but it's these patients that do have severe liver disease, especially those that have had a transplant, can we still use ETI and our other modulator therapies? So we're going to touch on that real quickly as well. So to go beyond the label, we have to start at the label, I guess. So let's understand what it says and why. We all know this. We are asked to check liver function tests, AST, ALT, and bilirubin every 3 months in the first year. If things are good, it's annually after that. But then we have this guide that AST or ALT 5 times the upper level of normal, or 3 times the upper level of normal with a bilirubin 2 times the upper level of normal, that we should stop the dose. And I think a lot of times patients get stopped with this, and then there's a lot of question as to what we do next. We have a little bit of guidance from the pamphlet as well, where we discuss the Child-Pugh score, the class, whether it be A, B, or C. For those that are not as familiar with this, I'm going to come back to it when we talk about a study here in a few slides. But obviously, if they're A, no adjustment, B, not recommended, we're going to come back to that in just a second. And then C is just really much don't use type of idea. We also know that ivacaftor, tezacaftor, and lexicaftor are metabolized in the CYP3A4 and 5 pathway. So ivacaftor is almost exclusively through CYP3A4, whereas tezacaftor and lexicaftor are CYP3A4 and 5. And so we do have these guiding dosage, especially for these strong inhibitors. Think of your azole medications that these patients might be on, And then the same thing for moderate. Don't want to get too much into that. I just want you to know that they're there. But this is where things start getting interesting, right? This is the precaution that came out. This was after ETI was initially approved. And what it tells us is that liver failure has been reported in a patient with cirrhosis and portal hypertension, and avoid use of Trikafta in patients with pre-existing advanced liver disease, except if the benefits are expected to outweigh the risks. Is that a medical recommendation or a legal one? Nobody needs to answer that. But, we get a little further into this. And again, if we do have these patients, the ask is if you are going to go ahead and use, and you think that risk is outweighed by the benefit, that you're going to closely monitor these patients. And anybody with pre-existing liver disease or pre-existing liver involvement in CF, we're going to monitor them in a different way, more closely, although we're not given a lot of guidance. I also want to take a step back on this. I was fortunate enough to be the consultant for the pediatric, or the grand rounds 2 years ago here at NACFC when this case was presented of the adult from Case Western that had acute liver failure. And I've looked and I've asked around, and I don't think this case has actually been published in the literature, but I happen to have my slides from a couple years ago in this biopsy. And for those in the room who don't always look at liver biopsies, you can see quite a bit of hepatocellular disarray. But what's more important is this interface hepatitis that you're seeing. And it may not be real clear, but there's actually a lot of plasma cells in there as well. We have bridging fibrosis on our trichome, and we even have rosettes. So this is really what you would think of as autoimmune hepatitis if you were to take away the CF picture. And it has begged the question as to whether this case alone was indeed an unrecognized autoimmune, or if it was drug injury that happened to look like autoimmune hepatitis. And I'm going to come back and touch on that point here in a little bit as well. So knowing that that's why the label says what it says about acute liver failure, maybe a little bit of question regarding it. Maybe, I don't know, I can't presume too much. I think we also have to remember our historical context. Not only do we have to basically interpret these liver enzymes with drug injury, but we have to remember that these patients have increase in their transaminase levels. So this is an older study from the group from Colorado that looked at patients over 15 years that were diagnosed with CF by newborn screen. And what you see is that they indeed almost all have at some point an increase in their AST, ALT, or GGT, many of which will be above that threshold of 3 times the upper level of normal or 5 times the upper level of normal. We also can't forget what we thought of as historical, or what I'll sometimes call classic CF liver involvement, or I'm just using CFLD, but understanding that that's the bucket term. So the graph on your left is the work from Sick Children's showing that those with advanced liver involvement, you guys have all seen this MRI, I'm sure, at some point with this really nodular liver portal hypertension and big spleen. This happens at around 10 years of age on average, or at least in the early teen years. So we're still looking for that patient that develops that advanced involvement. And then we know from the NIDDK's work, the co-work, showing that when we really look at the involvement of CF liver disease or CF liver involvement, it really does progress into adulthood. It's not something just of children, and it may even be a slightly different form of CF liver involvement. So we have to keep that in mind as we're interpreting our liver enzymes. So with that being our baseline, essentially our jumping off point, we know what the label says, we know historically that these are the things that we sort of been looking for. I think we can start to look at the clinical trials a little objectively and see what we can learn from them. So these are two of the phase 3 trials for ETI. The one on your right with the green bars did show us that we had elevation in AST and ALT of around 6%, and all liver adverse events was again around 6%. What's interesting was in the earlier trials, they didn't even really actually put the liver enzyme as an adverse effect. They had to go back and look at it. And what was kind of interesting is if you look at tezacaftor and ivacaftor, it was around 2% versus ETI, that was 4% in what was reported. But when they actually went back and looked at the data itself and looked at the labs, they actually found 0% in the tezacaftor ivacaftor group, but again around 10, 11% in the ETI group. So they really had to even go back and really understand from even our earliest phase 3 trials what was really going on. Easy way to jump forward is to go to Liver Talks. If you're not familiar, you can basically go to this NIDDK, NIH resource, basically type in any med and see what it tells you its association with drug-induced liver injury is. The caveat here is all the modulators are grouped together, whether they're highly effective or not. And what we see is that roughly 25% of subjects in clinical trials have had some degree of elevation of those three enzymes. Only about 2 to 5%, though, have had levels 3 times the upper level of normal, with the mass majority of them being asymptomatic and self-resolving. Probably most important, only 1 to 2% of subjects have required dose adjustment or discontinuation. When we look at that next group, though, that group that is not included in clinical trials, so do remember with all these phase 3 and all the other trials, if you had any history of liver involvement, you weren't allowed in the trial, right? If you had Gilbert's and you had a bilirubin that had nothing to do with anything, you're not in the trial, right? So these are all things that we had to think of with real life examples. So as promised, this is the table that explains the Child-Pugh score in the chart. And one thing that I want you to note is it's encephalopathy, it's ascites, it's bilirubin, it's albumin, and PT that gets you your points. In a class B, it's that moderate impairment, is 7 to 9 points, and you can see the scoring mechanism. These are all measures of hepatic function, not inflammation. So when you start thinking about AST, ALT, and even GGT, these are essentially inflammatory markers. It's hepatocellular or cholangiocyte inflammation. It's not necessarily function. So in this interesting study that was conducted in the Czech Republic and Slovakia, I wonder how they got that one together, but this was Vertex sponsored, and these are patients that had a Child-Pugh class B, 11 patients compared to 11 matched that did not have any hepatic involvement. They were kept in a clinical research center for 10 days, and then they followed them up. And what they did is they looked at the measurements of elezicaftor, tezacaftor, and ivacaftor, whether they were in the moderate hepatic impairment group, shown in gray, versus those that did not have any hepatic involvement, shown in green. And what they showed was there was between a 1.2 to 1.7-fold increase in these metabolites or drug levels in the serum that were higher in those with moderate impairment. You can see there's a big range, but they did use this to justify the idea that for those patients with moderate impairment, you should start on a modified dose, which is probably correct. But I think with these big confidence intervals and where you see this, it probably gives you the idea that there are a subset of patients, even with moderate impairment, that probably could benefit or at least tolerate a full dose. And so just because they have moderate impairment, if they're not getting that benefit that you really think they should be getting from their ETI therapy, it doesn't mean that you are completely restricted from going up if they're otherwise tolerating the medication. At least that's my interpretation. So going into what we're really interested in, what are we really seeing on a day-to-day basis, which I think all of us would agree 5 to 10% increase in transaminase levels is probably not the real-life experience, or at least it's certainly not mine. So we are starting to see in the last 18 months a number of articles that are coming out discussing the real-life experience for patients on ETI. This is just a summary of some of the more recent ones. Wanted to start with an adult study out of Manchester, England, where they looked at 255 adults that were on ETI for at least 12 months. Here's just kind of their general demographics, but I think what's interesting is when we look down here, I guess my cursor doesn't actually show up. Sorry about that. But you can see that about 30% of these patients actually had liver involvement. About 8% with cirrhosis, 3% with isolated portal hypertension, and 4 patients, or around 2%, that had had a liver transplant. So this was actually a pretty enriched population of patients that had liver involvement. And what they did is they looked at the baseline characteristics, 3 months, 6 months, 9, and 12 months over the top. And then you can see our enzymes ALT, AST, GGT, alkaline phosphatase, and bilirubin there on the left. Now, admittedly, this is a very busy slide, or a busy table. But what I want you to really look at is when you look at baseline, you can see that really across the board, there's very few patients, at least in this cohort, that really had increase in these liver indices above at least 2 times the upper level of normal. As you come across the screen to your right, you will start to see more and more patients reaching those thresholds of 3, 4, and 5 times the upper level of normal, even beyond that 3 months into 6, 9, and 12 months. And with the exception of alkaline phosphatase, they're all statistically significantly showing you that there are more patients with an increased transaminase elevation than there was at baseline. But what's really interesting to me is look at the medians. ALT median went from 20 to 26. That's not different. AST 22 to 26. That's not different. GGT 17 to 17 and a half. Bilirubin 6 to 9. So what this tells me is, yes, we are seeing more patients that have an increased number, but it's really a small subset that's probably really driving a lot of these changes. So there's those that really respond strongly, maybe have some real hepatic inflammation, but across the board, most patients are tolerating this pretty well. Well, we can break it down even further in this group, where you can look at those 8 cases of patients that had at least a 3 times upper level of normal for their ALT, all of which are also shown in the AST group, so we can just ignore that group for right now. And you can see some pretty significant elevations up to about 586 there. But what's interesting to me is look at all the alternative causes, and I think this is what's important from this study. One patient was drinking a lot of alcohol. They stopped their drinking their alcohol, their liver numbers improved. Viral illness went away, numbers improved. This patient didn't have any other alternative. They stopped for 4 months, they were able to come back on ETI. 2 patients on medications that were actually the contributors to their numbers going up, another patient that went back to baseline, patient that had a liver biopsy and went back on ETI, and a patient who had stones that improved after intervention. So even in this cohort of 255 adults, even those few that had an elevation in their transaminase levels, they had another cause that you could address. This same group actually followed these patients a little bit further, focusing on their liver stiffness measured by VCTE, or vibration-controlled transient elastography, APRI with the equation there in the corner for you if you need it, and GGT to platelet ratio. And really what you see is, following these patients out for, again, 12 months, you see no difference in their liver stiffness measurement. Their APRI score did increase a touch from 0.28 up to 0.33, but again, not really to that threshold that you think of as really being significant liver involvement. And their GGT to platelet ratio didn't change either. When you start breaking these patients down and look at whether they had no involvement, involvement without nodularity, involvement with nodularity, or their isolated portal hypertension, again, you see no difference between their change in liver stiffness, APRI, or GGT to platelet ratio. So it's really even hard, at least in this cohort, to say that those that are having more severe involvement had any improvement on this and was pretty well tolerated. Looking at some pediatric data, this is information that Zach Sellers and the group from Stanford gave us, comparing 42 patients on Luma ivacaftor compared to 52 on ETI. And I found this study very interesting because it was very different than my personal anecdotal experience, where I saw a ton of patients with Luma iva that had increase in transaminase levels. But what they actually showed was AST, ALT, and GGT percent from the upper level of normal, as well as platelets, APRI, and GGPPR, or again, the GGT to platelet ratio. Across the board, those on Luma iva actually did better, with a statistical significance in AST, ALT, and GGT going down, where in large, ETI was pretty stagnant. Same thing with platelets, again, APRI and GGT to platelet ratio. So I thought that was interesting that across the board, patients stayed pretty similar. There was a group from Italy who sort of looked at this a little bit differently, looking at liver stiffness measurements, again by VCTE. And amongst 55 patients with a median age of 17, so these were adolescents and young adults, you see that liver stiffness didn't really change at baseline, 1 month, 3 months, and 6 months. ALT went up maybe just a touch, but pretty stable, still at normal levels for the most part. Same thing for GGT. But when they broke this down into patients who had their initial baseline liver stiffness over 7 kilopascals, which you would think as being high risk for liver fibrosis, versus those in the moderate 5 to 7 kilopascals, and those that were normal less than 5, you actually saw that there was a decrease in the liver stiffness in that high-risk category. And essentially, in the medium risk, they had an initial decrease that then kind of leveled off, again, with those with the normal staying normal. Interestingly, though, those that had a higher liver stiffness at enrollment or at baseline actually all had an increase in their ALT and their GGT. And this led these authors to at least theorize that there might be some initial improvement in liver stiffness or hepatocellular recovery that actually resulted in these enzymes being spilled over to cause a transient increase in their liver enzymes. I don't know that I necessarily agree with that theory, but that's what they put forward and gives you even another thing to think about if you see an initial bump in your transaminase levels right after starting ETI. And the most robust data we have is obviously from the CF Registry and Vertex, where they looked at over 16,000 patients at our ETI for a median duration of 20.4 months. And what they did is they looked for the 5 years before starting ETI and then the 2 years after. And really what's the most interesting is if you look at minus 5 years and 1 year after, the numbers are exactly the same. At 2 years post, at least for ALT, there might be a subtle decrease in some of these numbers. For bilirubin, what's interesting is it was pretty stagnant for those 5 years leading up to ETI therapy, and there's this little jump. But as I mentioned earlier, I think we see a lot of indirect hyperbiliry with these patients. Some of it was probably undiagnosed Gilbert's, but we also know that these drugs suppress the OAT beta transporter and leads to some indirect hyperbilirubinemia as well. So my guess is what you're seeing here is really an indirect and not a direct, so nothing of significant concern. I got a little curious at this, and I actually just started looking at our data for our patients now that are between 2 and 5 to see what their experience was or what we're seeing in Columbus. So this is completely unpublished, and this is thanks to our pharmacist, Emily Steffen, who did all this for us. But what I saw was really if we looked at those patients 1 year before starting ETI, 17 of them had increased transaminase levels, with the majority of them actually being in our younger cohorts, our 2 and 3-year-olds. And if we looked at after initiation of ETI in this group of these 45 patients, it's still only about 19. It didn't change a whole lot. And again, by age, it didn't seem to make a big difference. And if we looked at the severity of the increase of the transaminase levels in this group, again, 26 were normal, 17 were in that 1 to 3 times the upper level of normal, and only 2 in the 3 to 5. So again, it's a pretty small group that really had an increase going on. But we do know there's reports that have been a little bit more concerning. So this was a patient that was on ETI for approximately 7 months out of, again, England, and started to have a bump in ALT, AST, and alkaline phosphatase. They tried to take the medicine away, recovered a little bit, started on just the morning dose, but continued to see an increase in these transaminase levels. They then stopped the medication, continued to see the levels rise, and then they got this liver biopsy. And again, I'm sorry my cursor's not working well, but what you see is a pretty significant pericentral necrosis going on. So this is real liver injury with no other alternative to explain it. Patient stopped the medication, and after several months, finally had a resolution of transaminase levels, has remained off medication and done well, but very likely had hepatic necrosis from ETI. Somewhat similarly, we have the report out of Johns Hopkins of another adult who had been on ETI for approximately 5 months when saw a bump in the transaminase levels as shown. They stopped after 5.5 months. Initially, it seemed like things got a little bit better. Then at 7 months, had a significant bump not only in AST and ALT, but you can see that the total bili and then the direct bili of 2.1. And this prompted the liver biopsy that you see on the side here. Again, you can see pericentral necrosis with increased inflammation. But interestingly, on this patient, you don't see that bridging fibrosis on the trichome there, suggesting this really was an acute event. Again, this patient came off ETI, has done well, has not needed transplant, not needed anything else, has just recovered. So I think taking all of that data, which admittedly is a bit of a whirlwind, and trying to put it into something that's a little bit of a take-home, generally, I used to think of things before ETI and before modulators. If I have an abnormal lab, I have an abnormal ultrasound, I was really trying to decide whether this was that 5 to 7% of patients with advanced CF liver involvement or whether this was that benign increase in transaminase levels. I think now we have to think a little bit broader. We have to think about drug-induced injury. I didn't even talk about steatosis and the BMI thing that got touched on, talking about these other entities that we may see. But I guess my big take-home is there's not one test, all right? Direct bilirubin, it goes up, it scares me, but even alone, that by one test is not the answer, okay? Increased elevation of the transaminase levels with anything else, I'm pretty permissive. I've scared a few people, a few parents, a few pulmonologists, but generally I've gotten by with it. Increases in bilirubin worry me if it's direct, but also APRI, GGT to platelet ratio, or platelets alone that are dropping. Remember, you have an inflammatory condition, even though we think of low platelets as being around 50 in other liver diseases. In CF, it may be a higher value. Liver stiffness, it maybe has a role, but there's a lot of intra and inter-observer variation. MRE or MRI with protein density fat fraction is becoming more a part of my algorithm. I used to be a no biopsy person. That's no longer how I am anymore. I do get biopsies more often, and then dose adjustments can work very well. This is a dose adjustment table. I'm not going to go through it because I'm running out of time and I want to catch up on some of the transplant stuff. But I think the big thing is just getting rid of that ivacaftor evening dose and then playing around with it a little bit. And there's lots of us that can help. So again, ETI after transplant, briefly, there are starting to become more studies available for this as well. This is 10 patients in the United States across several institutions who were started on both ETI and tacrolimus. We can see 2 in this yellow bar had to discontinue their ETI due to persistent elevation of transaminase levels. And the 3 patients in the green arrow actually needed a slightly decreased or an altered dose of ETI, but were able to tolerate it. You can see at the end, for the most part, patients had acceptable increase in their transaminase levels or were normal. And maybe more importantly, all but 3 of the patients needed a decreased dose of their tacrolimus due to interaction between the 2. In total, of the 8 patients, only 2 were on full dose ETI and full dose tacro. So that just points to the fact that you have to monitor these patients, but they can do very well. Of the 8 that remained on ETI, every one of them had improved quality of life and improved respiratory symptoms. 75% had improved FEV1, BMI improved in almost 90%, and you can see the LFTs and the hemoglobin A1C. Lastly, this is a study out of England, 4 patients, all of which had increase in their bilirubin and pretty significant increase in their ALT into the hundreds. All of them underwent liver biopsy. All were found to be normal for the most part with some dose adjustment. All did well. But this is one of the biopsies. And if you look, you once again see a little bit of this interface hepatitis going on, except for in this one, you're not seeing the plasma cells. And I've personally seen a couple of autoimmune triggered patients on, and so it does just kind of ask the question, what does drug-induced liver injury on these modulators look like? And is there an autoimmune component, or could it look like it? And I think that's something we're going to learn with more real-life experience. So in summary, if you treat patients with ETI, you're going to see increased transaminase elevations. Your differential should be broad. Likely many sources need to establish or confirm the diagnosis. We don't know the long-term impact yet of these meds on liver, and it can be used ETI safely post-transplant. You just have to have a modified protocol. So with that, I will be happy to take some questions. But not from Mike.
Not from me. Mike Narquist, Colorado. I will disclose before I ask the question that I consult on this exact liver toxicity, so I'll only talk about publicly available data. One question, Jay, then I'm going to make a comment about the enzyme levels from an educational standpoint. Were you able to find any data that actually describes toxicity related to drug dosing and drug levels?
No.
Right.
So there, but just so you know, I don't know if Jennifer is here or not. Gimbale she's currently at UAB. She's getting ready to leave, but she is actually measuring all 3 metabolites, and we did just have a study funded and approved that will be looking directly at this, looking at the transaminase levels and mass spec levels of these drugs. So maybe next year I'll have something for you.
Yeah, I've seen some data out of Europe, and there's no correlation. So I think the one comment is we do not know the mechanism of injury from ETI, so I think we have to be cautious.
Yep.
an explanation for the cutoffs. In the FDA, all these cutoffs are related to something that's called Hy's Law. So old hepatologists know a guy named Hy Zimmerman who did this. And they are used 3 times the upper limit, 3 times the upper with twice elevated bilirubin, 5 times or 10 times. They're used in early studies to predict whether a drug might have unsuspected hepatic toxicity associated with it. So I think we do have to be cautious when we look at this, because these have been historic markers for lots of drugs, suggesting that there can be severe acute hepatitis drug-induced with it. And they're typically pretty rare events. So while our experience, I agree, is in the real world is quite good, our experience has also uncovered at least 3 that we know of severe acute hepatitis. So I think that's really the message. You want to get the drug there, but you have to figure out the level of caution and level of anxiety around it.
No, I absolutely agree. And I mean, I didn't get into a lot of the modified dosing, and I got to say we've been creative at times with that modified dosing, because we do think it's a dose dependent, and we have patients that we see that their BMI and their FEV1 continues to improve or stays improved with much lower dosing than what we think, and then the patient's able to tolerate from a liver standpoint to get their transaminase levels back in the, let's just say, 60 or under type of range. And then I monitor these patients really closely. Quite frankly, if their direct bili goes up much at all, it may not even be a red flag on your Epic or whatever your choice of EMR is, I will pull the drug faster for that than I will a bump in their transaminase levels. But then it becomes weekly labs, if not even more frequent. I will say the worst patient that I had decompensated over about a 72-hour period, and ended up having a very autoimmune type picture, almost needed a bone marrow transplant for aplastic anemia after liver failure. So I have seen it go quickly, so I don't want to be too laissez-faire about me saying that I allow, elevation in transaminase levels. Don't think for a minute I don't keep a close eye on them.
Yeah. All right. Any other questions from the audience? I'm going to ask one question from online. How often are you using APRI in your practice with patients on highly effective modulators with elevated liver function tests, or how can APRI be used in clinical practice?
So I know a few of us have actually gone to Epic, and we've got it built in now. So we basically have a calculator, and so it goes into my note for every patient that I see. So I have a dedicated CF liver clinic where that's all I see for that clinic, and everybody's APRI from their most recent labs goes into it. Like most of these things, it's not a cutoff in my opinion, it's a trend. And so once those levels get over about 0.3, 0.35, they're getting close to that 0.4 cutoff and trending up in that direction. That's when I think about it more often, and that's how I'm using it.
Ask one more question.
Yeah. There's another question from online. Do you think we should adjust the second part of the 3 times upper limit of normal LFT modification to go from elevated total bilirubin to instead use elevated direct bilirubin?
Yeah, I very much pay attention to my direct versus my indirect. Again, kind of going back to the comment, it's not one test. So I don't think anything needs to be changed. I just think we need to understand the historical context within this disease, understand the possible complications and the trends, and when you should be worried. It's not going to be just one thing.
And as a follow-up to that, when do you consider using ursodiol?
Thank you, everybody.
We had to ask.
No.
They're all thinking it.
I'm not going to get up here and pretend like I don't. If I have patients that are nervous and I know that the medication's working, their lung function looks better, their weight looks better, but everybody's worried because that ALT is sitting at 90 or 100, what do we know URSO does? It makes the numbers better. It doesn't change anything. It just makes the numbers better. But I have that conversation with them. I don't hide it. I tell them I don't think it's doing anything, and I tell them it means I have to monitor them more closely because we're artificially changing things. So I'm not going to stand up here and lie to you and tell you I don't use it, but you have to be smart about how you do it.
Go ahead.
Okay.
Hi, Jay. It's Lauren Lazar from UT Southwestern in Dallas. And great talk. I think very real world things. My question, and I may have missed it, but what are you using as your cutoff value for ALT, AST, and GGT?
Yeah. And again, I don't mean to be like, I don't have a cutoff. I have some patients who come in and like they come to us, they're started on ETI and they've got transaminase levels of 80 and 90. And we talk about that and we say, we're going to go on it and that's fine. And if you go to 110, 120 and we don't see anything else, I might allow that. That might be fine. But if the patient comes in and their ALT's 15 when they start medicine and now they're at 90, that trend's different to me. That looks different. And yes, I'm getting ultrasound and yes, I'll be getting MRIs. And then sometimes I do get liver biopsy now. So again, for me, with this disease in particular, it's the trend, not the cutoff for me that typically gets my attention. Now, I'm not letting people with 500s go on, but generally that's my gestalt.
I guess I mean more for when you're calculating your APRI, because obviously you're trending that.
0.4 is what Dan's in here somewhere, I'm sure. And, that's what a lot of his data has shown is somewhere around that 0.4 cutoff. But again, once we get above 0.3, 0.35, and we're inching up, that gets my attention pretty quickly as well.
So when you're using the AST normal value for the calculation,
for that,
40,
I'd still use around 25 in NHANES, type data, yeah. For simplicity, when I'm explaining it to parents, I just say 30, but usually, still using the NHANES data. Sorry, I misunderstood.
I think this will be the last question.
Sorry.
No, go ahead. I'll ask.
I'm Miriam Ishanda from Western Michigan University. Should we screen those patients for alpha-1 antitrypsin? Because one of my patients got elevated quickly, and she was found to MZ. So I wonder, is like you said, there may be another reason, and
Oh, absolutely. I mean, these patients still deserve a chronic hepatitis workup. That's been established even in our transplant guidelines that we wrote a few years ago. We suggested that. And then we also know that the Z allele may impart an increased risk for more advanced disease. Now, that's been shown in fatty liver disease and other stuff. I don't know that it's CF specific. But yeah, I actually will monitor somebody that has a Z allele maybe a little bit more closely than I do somebody who has MM.
And I'm just going to put a plug in that the liver disease guidelines were accepted to hepatology and should be out soon. So keep checking hepatology this month.
All right, cool. All right, thanks everyone. I appreciate it.
Thank you, Jay.
Okay. And we have one more speaker, Dr. Mark Derleith. He is a former Digest awardee from 2019 to 22. He's an adult gastroenterologist at the University of Washington. He's a member of the CF clinical care team there, as well as GI Fellowship Program Director since 2020. His research efforts have included projects related to colon cancer screening and prevention in CF, and he is the site PI for NICE CF, and also involved in projects related to DIOS.
Thank you very much. All right, very good. Thank you very much to the organizers for inviting me. It's a pleasure to speak here. And I have the topic of constipation and bloating on highly effective modulator therapy, updates and challenges. Thank all of you for sticking around. I have no disclosures. Today I want to do a little bit of an overview of constipation, bloating, and distension. I want to talk about the pathophysiology of the CF gut and look at the prevalence of constipation and bloating in patients with CF. I'm going to talk about what we know about impact of CFTR modulators on these symptoms, and I'll talk about therapy considerations. So bloating, distension, and constipation are very interrelated issues, but they do have kind of separate definitions, and there's interplay between them. Abdominal bloating, typically described as a subjective feeling, fullness, swelling, trapped gas. Some patients may say their belly is inflamed, whereas distension is more of an objective, visible increase in abdominal girth, and patients may tell you their abdomen's like a balloon or like being pregnant. And finally, constipation typically has features of infrequent bowel movements, less than 3 per week, straining, incomplete evacuation, and hard stools. Important to note that all of these symptoms are very common features of what are known as disorders of gut-brain interaction, or DGBIs. And we know that These symptoms probably have a very likely pathophysiology that's unique in the setting of cystic fibrosis, but there can be overlap too, and so we need to keep that in mind. The physiology of the so-called CF gut includes a number of features, which I'm sure many of you or all of you are familiar with, but I'll go over those. There's reduced intraluminal fluid as well as increased viscosity. And this is all attributed to defective chloride and water secretion into the lumen via the CFTR protein. There's enhanced fluid uptake through sodium channels in the epithelium. And then there's components of dysmotility. We know that there's enteric neuromuscular dysfunction, and there's also fat malabsorption, which contributes potentially to the so-called ileal brake, which is a mechanism whereby certain substances set off kind of a slowdown in the motility of the small intestine. And those substances include things like free fatty acids and triglycerides, among others. There's also a component of intestinal inflammation, and we know that there's a decent prevalence of dysbiosis and small intestinal bacterial overgrowth, which I'll refer to as SIBO. So one of the key challenges that we have when we're seeing patients in the CF clinic for GI issues is differentiating constipation and bloating. Constipation and DIOS, I apologize. So I have side by side the criteria from NASPGAN to kind of identify these things. And you can see that there are common features. Both feature abdominal distension and pain. But constipation tends to be more of a slower onset, weeks to months, and it features reduced stool frequency as well as increased thickness or consistency of the stool. And often these patients with constipation will improve with laxatives. DIOS, on the other hand, has features of small intestine obstruction, and that can include imaging findings such as fluid levels. You may see in high-grade obstruction, you may see bilious vomiting, and you may also see fecal mass in the ileocecum. So there's been long considerations or thoughts about whether or not PERT dosing could have an impact, either positive or negative, on bloating and constipation. I think this study was already referenced by Dr. Chadwick, but this was a large cross-sectional study looking at over 1,000 patients at 33 sites. 90% of them were pancreatic insufficient. And what they found is that when they looked at reports of gassiness and constipation, they found that these complaints were much more common in patients who were pancreatic insufficient versus those who were pancreatic sufficient. And there was no difference in bowel frequency between the pancreatic insufficient and sufficient patients. They also noted, and Dr. Chadwick had this chart up in her presentation, that higher PERT dosing was not associated with less symptoms. We also know from a number of studies that there's a high prevalence of SIBO, or small intestinal bacterial overgrowth, in people with CF. And this is just a brief summary of 4 studies, which are all very heterogeneous. But you can see that there's approximately a 31 to 56% prevalence of SIBO in patients with CF, whereas in the controls, the range is roughly 7 to 20% from these studies. The GALAXY study was a study looking into GI symptom burden in cystic fibrosis. This is a 26-center study in the US looking at kids and adults, prospective observational. They looked at symptom assessments every week for 4 weeks. And these are the measures that they looked at. The colorful charts to the left of the screen include the 3 patient-reported outcome measures. You may all be familiar with these, but I'll just describe them briefly. The PAGI-SIM measure is a 6-domain measure with 20 items on it that really looks at a number of symptoms across the spectrum of GI issues. And it does include a bloating domain. The PAC-SIM questionnaire is a constipation questionnaire that has 3 domains, 12 items, and looks at features of constipation. And then the PAC-QOL is a constipation-related quality of life questionnaire. And the authors chose to also add separate assessments through what they called a subjective stool questionnaire, including 4 items. And these items included looking at bowel frequency. They included looking at self-described bowel pattern. This means, are you constipated? Do you have diarrhea? Do you have alternating bowel habits? And they looked at the Bristol stool scale. This is the only picture of poop that I'll show today, sorry. But most of you are probably aware, but type 1 and 2 stools tend to be lumpy, firm stools, and those are typically associated with constipation. So in the Galaxy study, they enrolled 400 patients. About 58% were adults. They were split pretty evenly between female and male sex at birth. Most of them were white patients. There was a small predominance of Latino and Black patients, among others, and they were 54% homozygous for the F508 deletion. Almost 90% were pancreatic insufficient, and notably, 41% of patients were on medications for constipation, and the majority of those were on polyethylene glycol. If you look at the chart on the right, this shows modulator use, and you can see that patients on any modulator, there were 57% that were on any modulator. And this study was done really before the approval of triple therapy, or ETI, and so there's a low percentage of patients on that therapy, just a few on study. They looked at patients who were on constipation meds versus those who were not on constipation meds. And what they found was that there was a higher GI symptom burden across all domains of the 3 patient-reported outcome measures. They also noted that there was poor quality of life related to constipation. And you can see that here on this chart by each of these points being to the right of the red line. They looked at self-reported bowel habits, as I mentioned. This is that question about, are you constipated or do you have diarrhea? And what you can see here in the dark blue is that both in adults and in kids, there's a large proportion of patients that report normal bowel habits. If you look at the yellow, you can see that about 9 to 10% of patients report being constipated, and another 5 to 10 report having alternating diarrhea or constipation. I'm going to just step back to just contrast that with or at least observe that we see 40% of patients on constipation meds. So this represents a lower percentage. Here again, we're looking at the Bristol stool scale. The gray zone is the normal bowel habits, or what we would consider normal, a Bristol scale of 3 to 5. And the dark blue includes the scores that we associate with constipation, which are the Bristol 1 and 2, the hard, lumpy stools. And you can see here also 10% to 12% actually reported the more watery liquid stools. They found that symptom scores were generally worse in female patients as well as adults. And they looked at moderate to severe symptoms, and they found that in adults, greater than 20% of patients had moderate to very severe is really the technical terms they use. So greater than 20% of adults and about 15% of kids had those. The moderate to very severe symptoms is defined by a PAC-SIM score of greater than or equal to 2, or a PAGI-SIM greater than or equal to 3. And finally, they found that CFTR modulator use did not appear to impact GI symptoms. Again, just noting that most of these patients were on dual therapy, not on triple therapy, of the patients who were on modulators. So I want to turn now to the PROMISE study. PROMISE GI, you've all probably heard about this several times. But this is a study looking at GI outcomes in patients who were going on triple therapy. So this was conducted at 56 centers throughout the U.S. It was a prospective observational study, including patients older than the age of 12 and those who were initiating triple therapy. They did basically the same assessments that were done in the Galaxy study, so I'm not going to show those again. We'll go ahead and move on to the results. Baseline findings, really just average age of 25, equally divided by male or female sex, and about 50% were CFTR modulator naive. Their baseline patient-reported outcome measures, you can see here the scores are all less than 1. They do this by basically taking each domain and taking the score for each domain, and then adding them up and dividing by the number of questions rather. So they basically get an average. And on these scores, what this represents is it represents presence of symptoms, but not severe symptoms, and more in the range of none to mild, kind of in that range, just a mild signal. You can also see that very few patients had any measures suggestive of constipation, Bristol type stools, constipation, self-reported constipation, and infrequent bowel movements. All were less than 6%. They looked at then symptom changes after 6 months of triple therapy. And basically what they found was they saw no change in bloating or rectal symptoms. Rectal symptoms comes from the PAC-SIM, or the constipation questionnaire. And they saw reduced symptoms in all other domains, but the reduction was, and it was statistically significant, but not likely clinically significant. There were limitations of this study. Like I said, they had a small proportion of patients with moderate to severe symptoms. And so the population was not enriched for that issue, and therefore the results are difficult to interpret in those patients. Medication changes were not followed during the study, including laxatives. But what we can take away from it is that most symptoms, GI symptoms, reduced on triple therapy, and they noted that especially in older female patients this was true, but the symptom reduction was likely not clinically significant, and they don't see improvement in constipation and bloating. There's another study out of Germany and also conducted in the UK looking at a score called the CF-ABD score, which is a patient-reported outcome measure developed specifically for the setting of cystic fibrosis and looking at abdominal symptoms. This has been validated and was used in this study. The score involves 5 domains and 28 questions, and one of the domains looks at disorders of bowel movements. I think I refer to that here as DBM in the next slide. So, but that's really the kind of constipation domain. They took 107 patients with cystic fibrosis, age greater than 14, and they gave them symptom questionnaires before triple therapy initiation, and then followed them up to 26 weeks with additional assessments. So their outcomes included really reduction in the CF-ABD score overall, as well as in each domain. And you can see here the DBM score reduced by 23%, which was a lower amplitude change than all the other domains. And while it did reduce over the course of, or when patients were on triple therapy, it was still higher than the control group that they had recruited. They had about 45 to 50 normal healthy controls that they compared to. I'll just, since I put this picture here, I'll guide you through it. You can see the red zone in this cool looking chart here is before starting triple therapy, and the blue zone is after or during triple therapy. And then you can see this little green shape here represents healthy controls, and each of these kind of points of the star are the separate domains, and the top one is the total CF-ABD score. It's a cool representation. Obviously, there are other studies and other things to talk about under this topic, but for the sake of time, I want to turn now and just talk a little bit about kind of what we do in treating constipation in cystic fibrosis, kind of what's standard therapy and what therapies are more second line or even third line considerations. So Generally, first-line therapies for constipation in cystic fibrosis include osmotic laxatives. In adults, that's most commonly polyethylene glycol. And these increase luminal water retention. And so many patients are on those, as we saw, 37% in the Galaxy study. And then in select patients, stimulants like senna and bisacodyl can be used to help with colonic motility. There are a number of second-line therapies, including secretagogues and prokinetic therapies. And those include lubiprostone, which has generated a lot of interest over the years because it activates the type 2 chloride channels in the lumen, and thereby potentially bypassing the defective CFTR protein. Linaclotide and plecanatide are both guanylate cyclase C agonists, and they activate the CFTR protein. Prucalopride is a serotonin agonist. And each of these therapies, I guess I should mention, linaclotide is the only one that I believe is approved in younger patients down to age 6, and the others are not approved for use under age 18, not FDA approved. I can't tell you much about the practical application of those medications in kids, but we use them a fair amount in adults. And so third-line therapies, I just wanted to mention tenapanor, which is approved in a recent few years. And this is a sodium hydrogen exchanger type 3 inhibitor, essentially inhibiting sodium and fluid from being absorbed across the intestinal lumen, thereby keeping fluid in the gut and increasing fluidity, decreasing viscosity. This is strictly contraindicated in kids below the age of 6, and it's discouraged below the age of 12. This is frankly a therapy that I've not prescribed yet, but I do have patients that I would consider it for. A brief look at a study looking at lubiprostone. We have very few studies in these second-line agents. So lubiprostone had a pilot study of 7 patients where they basically did, this is before the era of CFTR modulators, but they basically did a 2-week run-in period that served as their control, and then they did a 4-week treatment period giving lubiprostone, and they looked at symptom assessments along the way at week 0, 2, and 4. And what they found was that there was no improvement in bowel movement frequency or Bristol score, but they did see a significant reduction in the PAC-SIM score during therapy. This is a change in topic slightly, but this is another slightly off-label medication for bloating, in this case more commonly, rifaximin, tested in patients for SIBO in the setting of cystic fibrosis. Again, one of few trials looking at some of these off-label agents in the setting of cystic fibrosis. In this study, they took 79 patients and did a glucose breath test to evaluate for SIBO, and they also gave a symptom questionnaire. And they found that 31% of their patients were positive for SIBO. And those patients, they then offered to participate in a randomized controlled trial comparing rifaximin to no therapy. And what they found was that they had eradication of SIBO with rifaximin in 90% of patients versus 33% in the controls, but they didn't have very impressive symptom improvement. 40% of patients had symptom improvement in the rifaximin group, and again, 33% in controls. These are very small numbers, so we can't deduce too much, but interestingly, the 4 people who responded to rifaximin in terms of symptoms were all children under the age of 14, whereas none of the patients over the age of 14 responded in terms of symptoms. So to summarize kind of my thoughts about addressing constipation and bloating in people with CF, I think it is important to optimize pancreatic enzyme replacement therapy, but don't overtreat. We can't use this as a, we can't push this too hard given the data that we have. I should say we can push this too hard. Work with your CF dietitian. Carissa, our CF dietitian sitting right here. I work with her a lot. She's great. To make sure that your patients have healthy eating habits. Treat with medications for constipation. Consider various assessments and treatments. You can treat for SIBO if you think that that would be appropriate based on the patient's characteristics. Consider also the possibility of overlapping DGBIs or disorders of gut-brain interaction. And consider if you think that they have those or meet criteria for those, you might consider either behavioral or medical therapies for those. Don't forget to think about celiac disease. The prevalence of celiac disease in cystic fibrosis is probably 2 to 4% versus 1% in the general population. I've tested a lot of people. I can't say that I've diagnosed any primarily with celiac disease in the setting of cystic fibrosis, but I do think that we should keep it on our list. And then think about evaluating for pelvic floor dysfunction in your constipated patients, because there are potential therapies in that direction. Make sure to collaborate with the CF team on decisions regarding highly effective modulator therapy. That's my practice. That may differ across different centers, but certainly I rely on my team to help me out with decisions about that, as well as other medical therapies to make sure there's not interactions between drugs. Finally, let's just keep in mind that our patients have an increased risk of GI cancers, and many of them are young, and so we don't always think about those, but we have seen lots of young patients diagnosed with cancers, and so we want to have a low threshold to test with endoscopy or imaging if we have refractory symptoms or alarm symptoms. So brief take-homes: constipation and bloating are common in CF. Moderate to severe constipation is present in approximately 15 to 20% of patients with CF, according to these studies. They have a negative impact on quality of life, and so far we have really limited data to suggest that CFTR modulators have a huge impact on these symptoms, but I'm very hopeful that we may learn more as time goes on. And so I think it's obvious that we need further studies and long-term follow-up of CFTR modulators, as well as some of these emerging therapies for these symptoms. Thank you very much.
We will take any questions at this time.
Hi, my name is Kim. I'm the dietitian at Columbia University Medical Center, New York. So I know for the majority, people are having improved GI symptoms on ETI, but I do have like a small group of patients that are having worse symptoms, GI symptoms, more bloating, and abdominal discomfort. And I don't know if it's, now their lung function is so much better that now they're more focused on their GI symptoms, or it's something else. Is there anything that you suggest? I mean, I feel like I'm doing more enzyme changes with all of these patients now. Also looking at SIBO, but I feel like the enzyme changes are making somewhat of a difference, but I'm not really sure what's changing now that they're on ETI.
Yeah, first of all, about pancreatic enzyme dosing, I think there's relatively low risk in playing around a little bit with the dosing, as long as we're not getting extreme. I see brand changes. Sure, and we do that as well. Can I just ask, have you also worked in a general GI clinic or just in the cystic fibrosis clinic? Yeah, I guess the other. Okay, got it. Yeah. I guess the other comment I would make is just that bloating is quite a refractory symptom that we see across the board in GI clinics. So it is interesting to see now. And one thing I didn't bring up here is this time when these studies, Galaxy or especially Promise, was conducted. This is quite a dynamic time. So people on ETI having dramatic improvement in lung function, their lives are changed. They were on the transplant list one day, and then all of a sudden they're not coughing anymore. So in the back of my mind, I'm thinking exactly what you brought up, which is how can we be confident about these symptom assessments in that setting right there? It's a very dynamic setting. So I am very curious to see in the long term what happens. As for other tidbits, I think we have to work on treating constipation, make sure that we're not missing it, because clearly you can miss it if you're cursory with your history taking, and so we need to be asking not just are you constipated? They probably will not say they are. They may not say that, so you need to dig in a little bit. Great question that I use all the time. in my clinic, one of my favorite questions is to say, do you go a day without a bowel movement? And because a lot of people will say I have diarrhea all the time, and then you ask them if they have go a day without a bowel movement. And they say I go a week without a bowel movement pretty routinely. And so so I think it's important to screen for that. In terms of other things for bloating, I mean certainly dietary considerations are important because our patients many of them have had recommendations for high-fat diet and have developed very odd eating behavior, or I should say different eating behaviors than we may advocate for a person without CF, but like a high-fat diet, among other things. And so I think just screening to see what kind of their fiber content and what the balance is in their diet is important. So.
Hi, Andrew Prale from Nottingham in the UK. Thanks for a great talk.
Oh, thank you.
I'm a pediatric pulmonologist, so I know less about this than anybody else in the room, I imagine. But we did a series of studies looking at small bowel function and anatomy with MRI in Nottingham. And we've got some nice imaging looking at small bowel water content, which we didn't develop, our adult gastroenterology colleagues developed. And we found something that surprised us, which was the small bowel water content of people with CF was greater than that of age-matched controls, both in the adult and pediatric age ranges. And then a lot of the therapies that we give increase bowel water content, for instance, the treatments for constipation as well. So I just wondered what your thoughts were, whether if the driver of some of the symptoms could be small bowel water content, and if we could paradoxically be making it worse with some of the things that I routinely prescribe.
And are you referring to things like Miralax and lubiprostone or things like that?
No, just standard things like brand names like Movicol, the pegs and
osmotic
stuff.
laxatives. Sure, yeah. No, that's a great question. And I don't know enough about MRI to say for sure, but I wonder if the increased water content is truly because of just water substance in the bowel, or if it's a predominance of material in general in the bowel, and if that would show up as a water signal. I mean, it's solid stool or fecalization may not show up like the water signal you're describing, but like I said, I don't know quite enough about the MRI to show that. We do know that many people with CF will report no constipation, but if you look at imaging, they'll have a larger predominance of fecal material, and sometimes they have fecalization of the small bowel. So
thank you.
That's interesting. Thank you. Yeah.
All right, we'll take one last question.
Hi, Hillary Bashaw, Peds GI, Children's Healthcare of Atlanta and Emory. I focus on nutrition, so I was excited to hear you speaking to that and speaking about fiber. Has your group done much with the FODMAPs diet or using that more from the DGBI perspective? It's something I really haven't thought about a ton in this population, except for one patient who really didn't want to give it a try.
Yeah, understandably, right? Yeah. I've prescribed the low FODMAP diet many times, and I talk about it. It seems like 20 times a day with my patients. I educate my patients about it. It's I still do send people to dietitians to use this. Now I'm referring to all comers outside of the CF clinic. In the CF clinic, I don't think that I have referred many patients to get a low FODMAP diet, maybe one or two. But again, with the differences in eating recommendations, I'm always a little sensitive to kind of giving a very restrictive diet to someone who's already dealing with past recommendations that are tricky to manage. So it's a great question. I don't know the answer about how sensitive they are to the low FODMAP diet.
I think it's an area of opportunity as we're less focused on weight gain and all of that, and have some more flexibility and liberalization. So.
Yeah, absolutely. Thank you.
Great research idea. That's looking for a project. Well, thank you everyone for staying till the end, and thank you to our speakers one more time.